Well, thank you very much, Tor. When I was in training, my chief of surgery, Bill Fry, had some advice of be careful what you write about because you'll become an expert and then asked to talk about it and take care of patients with it. And so in our work with transcatheter aortic valves, we wrote early on about frailty, and so here I am talking about it. Most of the work on frailty has been done in surgery for transcatheter aortic valves, but a lot of it applies to all aspects of surgery. This is my conflict of interest disclosure. So frailty is a physiologic state marked by a vulnerability to stressors, and it's distinct from comorbidity and disability. Now, what does that mean? Well, if we look that frailty increases with age. About patients 65 years or older, about 8% have a frailty prevalence, but by the time you're 90, still only 40% are frail and 60% are not frail, which is probably a comment upon survival of the fittest. But it does increase with age, and rather than chronologic age, it probably is the highest predictor of longevity. In the field of aortic stenosis, it has not been well worked out how frailty is a confounder in terms of looking at outcomes. Now, if we just look at frailty in general, this is 754 elderly patients living in a community, of which 25% were frail at baseline. And this is work done here in New York by Dr. Freed, and found that it is dynamic. It's not static. Once you're frail, you don't necessarily always stay frail. And over a almost 5-year period of time, about 43% of patients transitioned to a higher state of frailty, and actually 23% got better or less frail. So this is a large cardiovascular study, Health in the Elderly, that looked at these 3 domains of disability, comorbidity, and frailty per se. And about 26% of patients were only frail, 46% of patients had frailty and at least one comorbidity, and 5.7% of patients had frailty and a disability as defined by activities of daily living, and 21% of patients were both frail, had comorbid factors, and had disability. So it's a phenotype, and it's characterized by weakness and muscle wasting. And indeed, you can look on CT scans and look at the psoas muscle diameter as a parameter of frailty. It's cognition and frequently associated with depression. Physical function of general fatigability, weight loss and impaired nutrition as manifested by serum albumin, and limited life space. Frequently, these individuals become more and more isolated. There are objective parameters of both physiology and pathology, from diminished mitochondrial function, cell senescence, changes in brain neurotransmitters, and altered inflammation and coagulation pathways. And as I mentioned, sarcopenia is a very robust objective measurement now using CT scans to measure muscle mass, as well as bone density and osteopenia as a measure of frailty. And indeed, there are a number of others, including C-statin, pulmonary function, and brain white matter grade, that are also manifestations of frailty. So how do we define it as surgery? Well, if we look at these 2 patients, and this both are 90 years old, both have an STS predicted risk of mortality of 12%. But every surgeon or every physician in the room can look at the patient on the right and know that this patient is going to be a much better candidate for surgery than the one on the left, because they simply passed the eyeball test. So the eyeball test is kind of like pornography, as described by Potter Stewart, the Supreme Court Justice. I can't define it, but I know it when I see it. And cardiac surgeons know it when we see it. And I'm not talking about pornography, I'm talking about frailty here. But we know it when we see it. But is there a way to objectify this? Well, clearly, everybody could define this patient as not frail. But we see very few patients like this. We see more often patients like this, and I think that everybody would agree that this patient is frail. This one, despite the fact that she's elderly and here in a wheelchair, I think a quick assessment would say she is not frail. This patient is frail. This one is not frail. All of these patients are 85 years old or older. This patient is frail. This one is not frail. This one is frail. Patients in bed oftentimes look frail. Just being in bed in this kind of allows patients not to necessarily pass the eyeball test. And patients should be evaluated when they are up and out of bed. And indeed, wheelchairs are the same thing. They tend to make patients look more frail, as well as canes. Now, are all of these patients frail? There's some reasons to think that they may be, but is there a way to objectify this? Well, there are greater than 20 multidimensional frailty scales out there, and they look at the following domains: slowness, weakness, low activity, exhaustion, cognitive impairment, nutrition, and then other factors. And it is a very robust field in the area of geriatrics. And this just gives 5 of the most common multidimensional frailty scales out there, and these 6 domains in which looked at. But this is very complicated, and there's not general agreement in the field. However, this can be distilled down to something relatively simple. And this is what's done in the partner trial and what we do in our high-risk aortic valve clinic. We measure 4 factors: gait speed by the timed 5-meter walk test that I'll spend a little bit of time talking about here, hand grip strength, CAT's activities of daily living, and serum albumin. And we put this all together as a frailty score. And then we correlate it with the eyeball test. So this is a study that looked at gait speed and survival in older adults that was published in JAMA last year. And this is a meta-analysis of 9 studies of over 34,000 patients. And these weren't patients undergoing surgery. These were patients in the community. And they did find that gait speed in and of itself was an independent predictor of survival in older adults. This looks at gait speed in cardiac surgery, and this is a study from Canada that looked at all patients undergoing cardiac surgery and looked at mortality and major morbidity as a function of gait speed as manifested by the 5-meter walk. And the conclusions were that gait speed is a simple and effective test that may identify a subset of elderly patients that have an incrementally higher risk of mortality and major morbidity after cardiac surgery. And that's shown very clearly in the next 2 slides. This is STS predicted risk of mortality or major morbidity, and this is the probability of it happening. And these are patients with normal gait speed, and you can see the higher the risk, the higher the chance that you have of dying or having a major complication after any surgery. However, if you look at slow gait patients, this whole curve shifts upwards. So it's an independent predictor of mortality over and above the STS risk score. That's shown in this slide that you can break patients into 4 groups based upon low or high STS risk score and low or normal gait. And gait on this is a binary outcome of greater or less than 6 seconds. And the patients with the better outcomes have a low STS risk score and normal gait, and those patients with a slow gait and highest STS risk score have the worst outcomes, with the other 2 groups being intermediate between those 2. So the 5-meter walk has been validated as a measure of frailty in the elderly. It's an independent predictor of outcomes after cardiac surgery. However, it has not been validated in patients with aortic stenosis or aortic disease, and it's not been demonstrated to correlate with outcomes after transcatheter valve therapy. This is how we evaluate patients for high risk for aortic valve and aortic surgery. Can you turn the sound on? So this is a multidisciplinary clinic of surgeons and cardiologists together. And while we are evaluating the echoes and imaging studies and catheterizations on these patients, we have a multidisciplinary heart team that's evaluating other aspects of patient care. So STS risk score is calculated, and then we have personnel that are measuring grip strength, doing activities of daily living, and all this takes about 15 minutes altogether. So after the grip strength, here you can see the patient doing a 5-meter walk test. And then all this is scored, and all this is done blinded to the physicians, and then a cardiologist and a surgeon together come in and evaluate the patient. And we currently have a study ongoing in which we are blinded to all these tests, and then we are seeing if we can objectify the eyeball test of what we feel looking at the patient. And then we're correlating these with outcomes of various therapies. So this is an example of a 92-year-old male and his 90-year-old wife. He has an STS predicted risk of 2.3%. He lives at home. He passed all his frailty tests, and he passed his 5-meter walk test. And so he would be a candidate for conventional surgery. She, on the other hand, failed all of her frailty tests, had a high STS predicted risk score, and had a slow 5-meter walk. So this is 337 patients that we've evaluated over the last little over 2 years, of which 332 patients went to a aortic valve procedure, 88 transapical, 160 transfemoral, and 49 aortic valve replacement, and 25 medical therapy only because of advanced frailty. And of these 337, 39% had a normal gait speed, but 54% had a very slow gait speed, and 7% were non-ambulatory. And I think that this is one of the patients that no matter what we're considering doing, that non-ambulation or immobility is probably the highest predictor of mortality or major complications afterwards. So as I said, we're in the middle right now of evaluating all this on a blinded basis and looking at all this outcomes, but we think that the 5-meter walk will be validated in this population. Now, all of this effort is to try to define what's euphemistically been called cohort C patients, or patients that are too sick for anything. And this comes out of the PARTNER trial, in which cohort B or extreme risk patients, are patients that are considered inoperable and therefore candidates for transcatheter valve therapy. Cohort A patients are high risk but operable. Cohort 2A patients are intermediate risk patients that are currently being studied in the PARTNER 2 trial. But what has come out of this is so-called cohort C patients that are too frail and too debilitated to even successfully undergo transcatheter valve therapy. And I'd say the majority of our efforts now are focusing on defining this population who are not candidates for any treatment. And it's trying to distinguish those patients who are dying from aortic stenosis with those patients who are dying with aortic stenosis, and despite successful treatment of their disease, in this case being aortic stenosis, die anyway. If we look at this one slide from the PARTNER B trial, and we look at the outcomes, the yellow is medical therapy, and the blue is transcatheter valve therapy, and this is 1-year survival of 30% at 12 months. This has been shown to be an overwhelmingly dramatic improvement in outcomes with a 20% absolute increase in survival. However, if you look at the glass half empty rather than half full, 30% of patients, despite successful therapy, still died at a year. The mortality was 5%, so another 25% died despite successful therapy. And this is the cohort C patients, and this is frailty and debility. And what everybody is working on now is trying to improve this survival by screening out the frail, debilitated patients who, despite successful intervention and therapy, do not survive a year. Now, there are a number of predicted risk algorithms for any surgery, and as you can see here, there's 8 different risk algorithms that have been available. The 2 most widely used are the STS and the Logistic Euro score. There are actually 4 new predictive risk algorithms that have been out just in the last 2 years: the ASEF score, the Australian Aortic Valve Replacement score. The STS has been upgraded to version 2.73, and now there is a new Euro score 2 that's been updated and expanded. The problem with all of these risk algorithms is that there's a number of factors that are not taken into account in the algorithms, either because the data wasn't collected because it was not known to be important, or because there were too few patients with those variables to validate. And as you can see, these are the common factors that are not included in the risk algorithms, with frailty being among them. The new version of the STS database, which was implemented in July of last year, now has new models that are relevant, new variables that are relevant, including liver disease, previous radiation therapy, porcelain aorta, and frailty as measured by the 5-meter walk test. So, in summary, frailty is a robust field of scientific inquiry. It can be defined both phenotypically and objectively. As defined by the 5-meter walk test, it is an independent predictor of mortality and major morbidity after cardiac surgery. It has not been demonstrated to be predictive yet in TAVR or TEVAR or in patients with aortic stenosis in general. The 5-meter walk test is now included in the STS database, and I think it will become a larger part of decision-making in elderly patients in the future. Thank you.